Hi guys, so we're going to talk about care of the patient with breast cancer. Okay, so our student learning objectives this time are assess breast lesions and options for breast cancer, collaborate with the interprofessional team about caring for the patient with breast cancer, discuss the psychosocial impact for the patient and family who have received a diagnosis of breast cancer. So, breast cancer can be non-invasive, which means it remains in the mammary ducts. Um, if it's invasive, which is much more common, it's where the cancer is in the surrounding breast tissue. Breast cancer that has metastasized is when the cancer cells spread beyond the breast tissue and lymph nodes via the blood and lymphatic system. And remember, the most common sites for breast cancer to metastasize to are bone, brain, lung, and liver. Okay? And that is important for you to know. Let's talk about some different, before we get into breast cancer in women, I do want to take a brief time to talk about some special cases with breast cancer, including breast cancer in men. It's rare. The rates are similar over the different races. Risk factors include previous radiation, family history, a BRCA mutation, if the gentleman has diabetes, has a history of gynecomastia, he can have testicular disorders and obesity. All of these increase his rate of having breast cancer. Another special group is young women with breast cancer. When young women have breast cancer, it's usually much more aggressive. And I know that I've misspelled the word weight. I see that, but I'm not going to change it. So just laugh at me and move on. But we want to teach the patients to seek treatment and not to watch and wait to see how it does. Because young women with breast cancer or with have a small nodule, it can grow so quickly and be so aggressive that before they actually look for treatment, that it can be too late and it can have already had a lot of metastasis. And one of the reasons is because, of course, they don't start screening until they're 40. But even if they do feel a small lump, a lot of times normal screening tools are not useful because women who are younger have much more dense breast tissue. Treatment for these women is also very unique. It puts them into early menopause. Can of course can lead to infertility and impaired sexuality as well. Other breast cancer risks are oral contraceptives, being female, of course, age greater than 65, breast density. The more dense your breasts are, the more risk you have for breast cancer, family history, your menstrual history as well. If you have an early onset of menses or a late start of menopause, obesity. So make sure you look at chart 70-1 on page 1442. It's going to behoove you to know the different risk factors for breast cancer. And then breast cancer, another special group is lifestyle related factors. Transgender, when you have a male transitioning to female, because of the amount of estrogen they take, and breast cancer being an estrogen dependent cancer, can lead to breast cancer in the transgender female. So with that, it's a very unique case because these women have now, these transgender women have now developed breasts, but they do not, they are still biologically male in a lot of cases. And so like on their driver's license or what have you, and so their insurance won't pay for mammograms. So a lot of times it's very interesting. It's one of the downfalls of this with the LGBT community that they're working on getting insurances to pay for screening tests for mammograms for the transgender female to be able to get that treatment, especially if she's been on extended estrogen therapies. Another unique group with your breast cancer related factors is your lesbian and bisexual group. A lot of times these women have later diagnoses, and it's a lot of times it's just because they have other um, risk factors that we will look at here in a minute, such as not having children, um, and a lot of times they have obesity as well. But lack of diagnosis can also be fear of discrimination or past negative experiences in OBGYN offices. I know now that a lot of, in larger cities such as Charlotte, um, there are GYNs who cater not only just to the LGBT community, but also to women who have not had children and who have no desire to have children. So they are just GYNs. They do not do the baby thing. And as a woman who's in that category, I choose to go to a provider that doesn't do OB, because I just feel like it's I feel as though that the GYN who doesn't do OB is much more able to relate and to work with the woman who has these special lifestyle choices, whether it's not having children, being in part of the lesbian, bisexual, LGBT community, or what have you. And sometimes it's just women who are later in life who just don't want to deal with the whole OB part of the OBGYN. So just keep in mind that there are some practices that are now helping with this, where people are having have had negative experiences in the past. They're catering to this subset of women, whether it be part of the LGBT community or heterosexual women who have chosen not to have children as well. So just keep that in mind that now that is being taken care of a little bit better. Health promotion and maintenance. Things that we need to do are we have the mammograms. We already talked about making sure that we know the ages on the mammograms when they should be started. If you're in a high risk group, you can have genetic testing for BRCA1 and 2. A lot of times these women will choose to have prophylactic mastectomies and prophylactic oophorectomies, which is the removal of your ovaries, which would put you into menopause. So that is something that women will do to prevent having breast cancer. So moving onward, so what do we need to know as far as the assessment goes? Well, anytime you're doing an assessment on a female, you need to make sure that you are getting her gynecological and obstetrical history. Is she aware of how to do self-breast exams? What is her family history of breast cancer? Is she of ages that she needs to be doing mammograms? And when was her last mammogram? Has she had any ultrasounds or biopsies on her breasts at some point? So these are all questions that you would want to make sure that you're going over as part of a assessment history for a patient who we were looking at breast cancer. These are a lot of times questions, of course, that they deal with at your GYN visits or your your family practice physician as well. First, we're going to look at some non-surgical management. They're usually, for breast cancer, they're usually complementary or integrative therapies. Look at table 70-2. A lot of times these breast cancer therapies are used to help cope with the physical and emotional aspects of breast cancer. These women a lot of times have a lot of body image issues, but most of the time they do not take the place of standard treatment. Sometimes women are non-surgical candidates due to the advancement of their cancer or their advanced age, and they may choose chemotherapy or some radiation therapy or a combination of both, or choose to go with palliative care. And a lot of times these women will still have some radiation therapy if there's discomfort in the breast itself or if it's metastasized into the lung, to decrease the size of tumors to ease their breathing abilities as well. So make sure you look at table 70-2.